their small-town touch. Whether it's broken hearts or broken bones, they dispense their own brand of Southern comfort. Is a veteran paramedic with the National Fire Department.
I look at it on the avenue that God has given everybody talent. Some people have several, some people only have one or two. This is my particular talent. I feel that's what He has in store for me to do. Been doing it for 20 years now. And I'm still enjoying the job. And it's something that comes to me easy.
Bill is responding to a call from a downtown hotel where a man is complaining of severe chest pains.
Oh, yeah. Right there in your chest, both arms. Does your pain get any worse when you take a breath in? Okay.
Danny Atkinson was in Nashville for a night out on the town.
We'll get you out here on this stretcher, partner. Did he eat anything different?
He ate a steak. Here's the lobby. Other than that, that's all we had.
Okay. Step up for me, turn right around, and have a seat again. Come on, friend. Stand up for me. History of seizures. His skin color, what he was sweating like he was, the problems that he was having breathing, and the pain were all very strong indications that he was having a major heart attack right there. Danny, can you hear me? Danny, give me some rest for me, buddy. Danny!
Danny, breathe, Mama!
Okay.
Danny Atkinson has stopped breathing.
Breathe, Danny!
Give me a hand in the bag.
Breathe, Danny!
Everybody clear? Look right here.
Breathe,
Step
Mama!
back. Step back.
Breathe, Mama! Please breathe! Breathe, Danny! Breathe, Danny!
You're right on the edge. Because you want it so bad, you know, to get something accomplished. And it seems like what you're doing is not working.
Breathe, Danny!
You have to keep it under control.
Danny, this time, breathe!
Danny's heart has stopped. Bill must revive Danny quickly, or he will die. Bill is trying desperately to get a sign of life from Danny.
You got folks on this?
Breathe, Danny! Breathe, Papa! Breathe for me!
Please breathe.
Come on, Danny, breathe for me, double.
We got a weak pulse with it. Let's go ahead and get him down here.
Y'all ready?
Bill has brought Danny back. Now he needs to get him to a hospital.
It's all right, Danny. Good deep rest for me, bro. The heart, brain, and other organs of the body were without oxygen for a certain amount of time. That's the way. I like seeing them eyes open. It's really hard to get something back after that process starts. Yeah, I know it does. You're going to be okay. We just got a lot of things to do here, Danny, right now. All right, brother. You're doing fine.
Paramedic Bill Blames is rushing Danny Atkinson to the hospital. Danny has had a massive heart attack.
300 at this time. I'm showing us on the stack at 120. Nitroglycerin sublingual times 1 en route. We're pulling into your ER at this time. The fish report will be inside. breathing on his own. But when it's that long of a period of time between the arrest itself and advanced life treatment, usually the outcome of that is not real good.
How we doing, man? You hurting? All right, well, we're getting ready to fix that.
That's what we had.
He went out with it.
He was unconscious and
So, cardio again? He was shot. He was 300, and was 300. He's converted.
It's a team effort all the way around. And when it works well, it's like a machine.
Blood pressure was 160 over 100. How many? You burned it out real good. You know what I mean? Danny's is first. Danny Red. Thank you, sir.
Hit that start button on that blood pressure cuff already. Oh my God, it is.
Dr. Davidson, can you hear me?
This was a really good call as far as doing a conversion and everything. He went into what's called a coarse VFib, and we defibrillated him at 200 and also at 300. He converted into a sinus attack with a pulse without it. Experienced excellent results on that. That's a good sign of what quick the early defibrillation can do. Converted him right into a viable rhythm from a rhythm that was going to kill him. Appreciate it. Really good. Thank you.
Very sick. 65 southbound, 1 mile before the EMT Road.
Like I said, man, when it turns out good, it's a good feeling. It's one that makes you feel good that you've been able to help, been able to make a change in what happened. It's the best way to lead the ship right there.
So, what was your first general impression of the patient? Like, if that was you when you're going into the room, what would be your first impression? Yeah. If you're a little guy like me, that'd be like, oh, geez, this will hurt. But what was, like, medical-wise, what was your first impression when you looked at the condition of the patient? Could you tell anything from just looking at him? Huh? Okay. Right. Notice how pale he was, even on the pixelated video. You could sort of pick up, man, he was sort of sitting up, tripoded, and he was in distress. If I would have walked in on that patient, I would immediately put the defibrillation pads on him. So I'm thinking, he's about to code. I mean, you sort of get all that together, get all that information together, you know, very quickly, and you sort of look at that patient going, that guy's in distress, he's having a heart attack. All right, so you prepare yourself for that. The little thing that he went into, did you hear the guy saying, does he have any history of seizures? It's called a VFib seizure. Most everybody that I've seen that witnessed arrest, that goes into cardiac arrest with me there or whoever there, does the little seizure thing. They have a little VFib seizure. Their draw up is called the corticate posturing. We'll learn about that later, but they draw inward and then they seize. And when they do that, the greater majority of the time they're in ventricular fibrillation. That's why they call it a VFib seizure. Because you know they're seizing. So that's why I would never want to get put on TV, because now you have people of the know looking at that and going, what mistakes did they make, right? Can y'all pick up the mistake? What do you think one of the mistakes that they made? Yeah, the CPR almost looked fake, didn't it? I mean, it wasn't fake, but it looked like for show. Huh? Yeah, they had non-breather on them.
That dude that was breathing for him was breathing really fast for him.
Huh?
That dude that was breathing for him,
Really fast for them? You know.
And he like stopped for a second. We used to do CPR. He stopped. And I was like, I don't know. He just thought I was like,
See, it all looks a little different in real life than what it does, like on the video, like a practice video, you know. But that happened. Those things will happen. I mean, you're sitting there. This guy's probably got this running through his mind. Okay, what's next? Because he's trying to play out this scenario. What are we going to do next? And they're getting ready to defibrillate him. All right. Now, I'm not sure the time period that was taken. It was taken some time ago, because if you notice the monitor is that one up there. It was the same monitor, and that one's pretty old. All right, and they don't do the paddles anymore. They do the hands free. So it's a little dated, but the video was good to sort of look at and examine. I mean, we would have went in and put the pads on them. What I would have done, I think, and it's always easier to say this is what I would have done watching a video instead of right in the middle of the battle. But I think we would put the leads on him first and see what rhythm he was in, and then just his general impression, I would have went ahead and put the defibrillation pads on him. That way everything is set up. You had to get him upright to move him to the cot. That wasn't a problem. However, one thing, like if the cot was over there, you couldn't get the cot in, and the cot was way over there. It would have been against the standard of care. Let's say the patient's over here, and the cot's over there where Mary is, and you can't get the cot in here. Let's say something's too small and you can't get the cot in here. And he's a big patient, right? How are you going to get that patient from there to the cot? Yeah, you could put him on a backboard. That'd probably save us something, but how else? Yeah. Either way, you'd carry the patient, right? You wouldn't allow the patient to walk over there. Because if the patient got here and walked over there and coded in the middle, then that would have been a big, huge mistake. And you never say never, but always try not to have someone having chest pain walk. It's going to increase the oxygen demand of the heart. Alright, another quick video, and this actually explains quite a bit. Con does a great job.
I think most of us know what the heart does in our body. It pumps the blood, and in particular, it takes in the blood from the rest of the body. And it's blue over here in this diagram because that blood does not carry oxygen. And it pumps that blood to the lungs, where that blood gets oxygenated. It gets oxygen, and then it comes back from the lungs, and then they depict it as red blood now that it has oxygen in it. And then that oxygenated blood is then pumped to the rest of the body. And I think also most of us have this general idea that when people talk about heart disease or heart attacks, which we'll learn are two different things, related but different things, that it has something to do with the clogging of arteries. And so when I was a kid and I first learned about the clogging of arteries, and I knew enough to know that the heart is all about pumping blood through the body, I assumed that the arteries that people were talking about were these big arteries, the arteries that are coming away from the heart to the rest of the body, that somehow these things got clogged up. So let me draw that different color you can see. So this was this is what I thought people were talking about when they were saying clogging of the arteries. And maybe once this got clogged enough, it stopped the blood flow to the rest of the body somehow, and that would actually kill the person. And what I want to make very clear right now is that those are not the arteries that people are talking about getting clogged when people talk about heart disease or heart attacks. The arteries that they are talking about are the arteries that actually provide blood to the heart. Remember, the heart itself is a muscle. It itself needs oxygen. And so you have these arteries right over here. So these red tubes that are depicted on this picture, those are arteries. And then the blue ones are veins. They're taking the deoxygenated blood away from the muscle tissue of the heart. And these are called coronary arteries. And this one over here, at least from the point of view of me or you, looks like it's on the right, but from the point of view of the person whose heart it is, this is on the left. And so this right over here is called the left coronary artery, or the LCA. And this right over here in red, this is called the right coronary artery, or the RCA. And so when people talk about arteries getting blocked or arteries getting clogged, they're talking about the coronary arteries. They're talking about the things that supply the blood to the heart. And so let's zoom in on one of them. So maybe we could zoom in right over here. So if we zoom in right over here, that part of an artery, that's the tube. Let me zoom in, make it a little bit clearer where I'm zooming in. So I'm zooming in right over there. So over time, and I'm not going to go into the details of how this happens, that's maybe a subject for another video, you can have these plaques build up along the walls of the artery. So if you zoom in over time, if the person doesn't have the right diet, or maybe they just have a predisposition to it, you can have these things called plaques form on the walls of the arteries. And the plaques, the material inside of them are lipids, so things like fat, cholesterol, and also dead white blood cells. So it's this kind of messy substance right over here. And this is what we call a plaque. And the formation of these plaques that obstruct the actual blood vessel, that actually obstruct the artery, we call this, let me make it clear that you see this. This is a kind of a tube right over here. Let me draw the blood. So this formation of a plaque we call atherosclerosis. Atherosclerosis. And so you can imagine, if you have these things build up, it's narrowing the actual vessel that's supplying blood to the rest, to downstream from that obstruction. So it would be disrupting the blood flow downstream. So it would be disrupting the blood flow right over there. And that general process that we talk about, of that restriction of blood flow, that ischemia that's happening. So ischemia is the deprivation of blood flow and oxygen downstream from this right over there. That's what we call coronary heart disease, or coronary artery disease, or heart disease. Let me write this down. So this causes coronary artery disease, which is sometimes called heart disease. Saying coronary heart disease would be redundant, because coronary is also already referring to the heart. So another way, this is also sometimes called heart disease. Heart disease. And so you can imagine, if the downstream, the muscle tissue is not getting all the oxygen it needs, especially maybe when this person's, whoever's heart this is, when they're exerting themselves, they need more oxygen. The heart needs to pump a little bit harder. If downstream these cells are not getting all of the oxygen they need, you can imagine that the heart maybe is not able to provide all of the functions that whoever's heart this is, that they need it to do. And when that happens, that's called heart failure. Heart failure. So heart disease is one of the causes of heart failure. Heart failure. Now I want to be clear, heart failure does not mean that the heart is stopping, that the heart is stopped and that the person is dead. It literally just means that the heart is failing to do what it should be doing. It's failing to provide the needs of that person. So it's not pumping hard enough, or it's not pumping well enough to provide, I guess, adequate function for that person. The other symptom that actually might occur when someone has coronary artery disease, where they have this obstruction, where you have this ischemia, this deprivation of oxygen downstream from this obstruction, is that they might experience this kind of strangling chest pain, and that's called angina pectoris. Sometimes angina, very few people see the pectoris part, but sometimes you hear people say, oh, he has angina. That could also lead to angina pectoris, which is really chest pain. And angina literally comes from meaning kind of the strangling feeling, and then the pectoris is in the chest. So it's literally a strangling feeling in the chest, and this is a symptom of heart disease. Now, this is already not a situation you want to go get into, because already your body is not able to function as well as it maybe could be, as well as it could. But sometimes, so what I've just described here is a plaque, but some plaques are actually unstable. So this plaque could just grow and grow and grow, and it would make probably the heart disease worse and worse, and the heart failure worse, and the angina pectoris worse. But if this plaque is unstable, it can actually rupture. So you can imagine all this blood flow as this plaque grows. The blood flow becomes a little turbulent around it. The blood flow becomes turbulent around this plaque. I'm drawing the blood kind of, because it has to go really fast through this narrow section, and it comes out turbulent on the other side. It can create all of these frictions and all the rest. And at some point, you could imagine that this plaque is unstable, and it could actually rupture. So let me draw a ruptured plaque over here. So let me try to draw the same one, but I'm going to draw it ruptured. So now this plaque has ruptured. It got so big, and maybe the turbulent blood flow helped stimulate this and whatever else, but for whatever reason, it ruptures. So it ruptures. And when it ruptures, now all of a sudden, and I'm doing a simplification of the process right over here, now all of a sudden the contents of this plaque, the lipids, the cholesterol, the fats, the dead white blood cells are now all of a sudden exposed to the blood flow, and in particular to the clotting factors in the blood. And this is highly thrombogenic material. Thrombogenic. Very fancy word, thrombogenic. But that just means that it tends to cause blood clots. So thrombosis is a blood clot. So what happens is as soon as this type of thing happens, and it could literally happen in seconds or even minutes, all of a sudden you could have these clotting factors form a clot right over here, right at the actual plaque. And as this happens, it starts to really, really, really obstruct the blood vessel. And sometimes it could even completely obstruct the blood vessel. And when this happens, you are significantly depleting the blood flow going downstream from there, or you might even be shutting it off. And when you do that, the cells downflow, the cells downstream, I should say, the cells downstream will no longer get oxygen, and they will die. And this right over here is called an infarction, so that is an infarction. Infarction. An infarct is actually dead heart tissue. And so you can imagine once heart tissue begins to die, so then when the heart tissue begins to die, this is even worse than what we were describing with coronary artery disease. Now, not only were they, with coronary artery disease, they're just not getting enough oxygen, now they're actually dead. They're turning into dead tissue. And this process of completely or almost completely or completely depriving cells of oxygen so that they die, this is a heart attack. This right over here. So let me completely obstruct this artery to make the point clear. This right over here is a heart attack. This is the primary cause of a heart attack. It's less likely, but sometimes the plaque could also go downstream and kind of form a thromboembolism. So it would be a clot. It would be this thrombogenic material that clots around it, and then it would actually go and block an artery further downstream and be an embolism. And so that could also block the artery and cause tissue to die. But the main cause is just this intense clotting that can occur pretty quickly and completely obstruct the artery. Now there's one last word I want to touch on because it sometimes is mixed in with all of these other words, and that is cardiac arrest. And that's because sometimes they're used in the same context, and these things can lead, one thing can lead to another, but cardiac arrest, a heart attack is not cardiac arrest. Cardiac arrest is the actual dying of the heart. What I've just described in a heart attack, people can have a heart attack, and they will have some part of their muscle tissue die, some part infarct, and that's why they call it a myocardial infarction. Myocardium is the tissue of the heart, is the muscle of the heart, and it is dying. So they call it sometimes a heart attack. It's called a myocardial infarction. That is not cardiac arrest, because you can have some of your heart tissue die and you can survive. Your heart will be impaired, but you will continue to live. Cardiac arrest is literally your heart stopping, and this would obviously cause someone to die. So cardiac arrest is literally your heart stopping. So if you have a bad enough heart attack, if you have enough of your tissue get starved of oxygen so that it dies, so that it becomes infarction occurs, then it could lead to cardiac arrest, but it always won't lead to cardiac arrest. And frankly, a heart attack is not the only thing that can cause cardiac arrest. And I also once again want to differentiate cardiac arrest from heart failure, because they sound the same. It sounds like the heart is failing. But cardiac arrest is the heart stopping. Heart failure is essentially just saying that the heart cannot provide all of the needs for the body.
Yes?
What if the heart attack stop the heart anyway, so is it the same as cardiac arrest?
No, not all the time. But if it's going to cause, if the patient's having a heart attack and there's enough surface area of the heart affected, in that weird word infarction, if there's enough dead tissue around on the heart, then it could cause cardiac arrest. But if we look at this heart here, if let's say that the clot's right down in here and you've got a small surface area right in here, that's not going to cause cardiac arrest. If the clot is up here and you have a large surface area here that is now infarcted or dead tissue, that's enough surface area to cause cardiac arrest. So it depends on the surface area, really, if the heart's going to stop.
You still do the same thing? You still just going to do the same thing?
Yeah, you still do the same thing. Yeah, for the heart attack. He didn't mention a few. Did a good job. Almost did all my job there. I could just play that, but he didn't go over a few of the newer terms that are used, and some of them are ACS or acute coronary syndrome. That's just a blanket term that's telling you that somewhere in the heart, ischemia, that might be a new word for you. For you guys, I don't know if y'all heard of ischemic tissue, ischemia. Ischemia or lack of oxygen. So you have acute coronary syndrome. When you have that, it's usually due to ischemia of some sort or the lack of oxygen. And then the other blanket term is just cardiac compromise, and that's a problem, any heart problem. CHF could be cardiac compromise. All right, trauma could be cardiac compromise. Any problem with the heart, sort of a big blanket term there that covers that. So, just like Con was saying, these arteries, over a period of time, and we can't really stop the time. I mean, it begins about age 2, where these arteries start building up that plaque. It just depends on, like, you guys are young enough to really reverse it. You know, stay away from McDonald's and all that other stuff. Those fatty foods, exercise, keep your blood pressure down. You know, watch your weight, don't pick up that freshman 15 next year. You know, all these things will take place over a period of time. So as the plaque continues, you can see the passage for blood is getting much smaller and smaller. So less blood is more blood here, less blood here, obviously. But what's the other problem here that's taking place between this one and this one? Huh?
It's getting bigger.
Well, the diameter of the vessel is getting smaller. Pressure, right. Greater amount of pressure. Like if you were to take a water hose and just let the water come out, there's not much pressure, but if you put your thumb over the hole of the water, it's going to shoot out, right? It's going to build up more pressure in that vessel. The problem with the pressure in the vessel, blood pressure, right, is that pressure could break off part of that plaque, and now you have what Con was calling an embolism. An embolism is something that goes from one part of the body to another. So this could break off, and it could travel further down that coronary artery, causing, you know, a full blockage, then causing a heart attack, right? Or no oxygen taking place, or a great amount of pressure could cause an aneurysm where this vessel would burst, and then your life expectancy is not very long after that. So there's a number of problems with the pressure, especially in the larger arteries. So when we look at cardiac-related chest pain, saying that this guy more than likely is having a heart attack. And that's what we're going to think of. Anytime, just a good rule of thumb, I still stick to this rule of thumb. When somebody tells me that they're having chest pain, they're having a heart attack until I can prove otherwise. I'm always thinking that patient's having a heart attack. If not, then you're going to get caught short. I almost got caught with a 20, how old was that guy? He was in his 20s. And he was having a pretty significant heart attack. Everything was looking like respiratory up until the point we did a 12 lead on him, and it showed that he was having a MI. So you have to be real careful. So rule out or prove that these guys are not having a heart attack. EMT-wise, you don't have to worry about that. They're having a heart attack based on their signs and symptoms, and you let somebody else rule that out, right? Okay, so some signs and symptoms that we'll look at: chest pain, substernal, usually a squeezing or a strangling type of pressure. It feels like someone's sitting on you. The patient sometimes will say, hey, it feels like someone's sitting on me. I have all this pressure in my chest. Pressure and pain are the same. They're treated the same. Right? It may radiate both arms, left arm, jaw, neck, back. Right? So you get the radiating pain there. The big one is the pressure pain. And with that pressure pain, it remains constant. It doesn't increase or decrease with respiration. It is a constant type of pain. Remember also here, that's where you would insert that severity, that scale 1 to 10. Other signs: shortness of breath. Patient gets short of breath. He starts to get nauseated, and then / vomiting. So pretty much, you got the scale here, and you got chest pain over here, all right? And you start adding up signs and symptoms. So he's having pressure-related pain, pressure pain in his chest, short of breath, nauseated. Boom, you're having a heart attack, all right? Until proven otherwise. And I mean proven otherwise, they may need to go to the doctor. I mean the hospital. Obviously they need to go to the doctor. But when they go to the hospital, they'll do the 12 leads, they'll draw blood. But if they're nauseated and vomiting and having chest pain, more than likely they're having a heart attack. Sweating or diaphoretic, use the medical word there. In weakness, they feel real weak. They can't seem like they can walk across the room.
What causes people having heart attacks to vomit?
The pain for one. Let's say the simple thing would be pain. Let's say I took this golf club and I hit you in the kneecap with it. You feel like I'm vomiting? Yeah, I know you would. If you took it there and you said you took this and you hit me in the knee, more than likely I think I'm gonna vomit because of the pain, the amount of pain. The other thing that causes them to do that is when you start talking about the vagus nerve. We talked about vagal stimulus before. The vagus nerve lays over the heart and also the stomach, the part of the stomach. And when that nerve is activated, it's going to affect the stomach as well. But primarily, I think, because of the pain they're in. All right. So we talked about Con talked about angina pectoris or chest pain. When someone is having angina pectoris or chest pain, all right, they're not necessarily having a heart attack. Remember that. Then all you know right now is they're just having this chest pain. It usually comes from the ischemia, or lack of blood flow.
I have a question. If they're some people with heart attacks, they're still conscious. Would you still is that true? Would they still be conscious? Like that guy who's having a heart attack, would he still be conscious? And I knew he was having a heart attack. Can I do CPR on him, or do I have to wait till he's unconscious? Would that hurt him if I did CPR?
Well, you would. it wouldn't be indicated to do CPR until cardiac arrest. So you'd have the angina, the chest pain here in the substernal arms, usually due to the ischemic tissue, the lack of oxygen. Right? There's a couple different types of chest pain or angina. There's stable and unstable. Stable is here. You got this blockage. Maybe you have a patient who had a previous heart attack. All right? So you got this guy who's had a previous heart attack, and he's got to work still. You know, you can have a heart attack and still work, still be fully functional. It's no problem, depending on the surface area. But this guy knows every time that he goes to work and every time he has to maybe cut the grass, that he's going to start having this chest pain. So what do you think he does? It's time to cut the grass. Heart patient knows he's going to have chest pain. What do you think this guy does before he goes out and cuts the grass? Takes what kind of medicine? This guy takes aspirin every day. Yeah. More than likely, when he starts cutting grass, he's going to stop and take a nitro. He knows it's predictable that with the exertion or hard work that he's going to start having some type of chest pain. It's stable, or use the other word, predictable. So he goes out, he works in the yard, starts having chest pain, he takes a nitro, and it goes away. Or he might come inside and rest, and the pain will go away. So that's very stable. It's very predictable. The other one is unstable, or USA, and this is where it gets into, let's say, the same patient, but now he's having chest pain that wakes him up in the middle of the night. He's not doing anything. He's sitting on the couch watching, Texas stomp OU. Maybe he's an OU fan. He started having a little chest pain. All right? So, or typically it happens at night, or while they're resting, they start having this same type of cardiac pain. That is unpredictable, or USA. That's time that it's time to go to the hospital. Unstable angina is the time that you want to go to the hospital. Still may not be having a heart attack, but now the pain has moved from being very predictable to unpredictable. It's time to get another cardiac cath. All right? So if this patient was to go into the ER with USA, then they would say, oh, we're going to put you in the cath lab. We're going to go ahead and cath you, see what's going on. That way they don't take any risk of him going into cardiac arrest, right? Everybody good on the two types of angina? Now they're still not having a heart attack here. They're still just having this chest pain. And it will eventually go away. Even the unstable angina, you give the patient the medicine, the nitroglycerin, some oxygen, some rest, and the pain will go away. That's the distinction between someone having a heart attack and someone having angina. The heart attack pain usually will not go away until the blockage is fixed. Angina pain, just normal chest pain, stable or unstable, will go away with the medication or rest or oxygen or the combination. Is everybody good there? Then you get the AMI or acute myocardial infarction, where you actually had the tissue death. Now you have a complete blockage here. All right, there's no oxygen being formed up in here to this part, and now the tissue's dying off. No oxygen, tissue death. Now it's infarcted, and this dead tissue doesn't come back. You can't regenerate that. So this is quite, on this picture, this is quite a surface area here. That's what would cause, more than likely, sudden cardiac arrest. That's a huge surface area, very high up in that coronary artery. So that's probably going to cause sudden cardiac arrest. If it was down here in one of these smaller coronary arteries, then yeah, they're still having a heart attack, but no death from it. People have heart attacks all the time without knowing it. There's no telling how many I probably had. You know, just you get some chest pain, it goes away. You don't really think too much about it, and it could be a small heart attack. When they say small heart attack, they mean a small vessel with a small amount of surface area. All right. The good thing for you guys, the treatment's the same, because we're going to EMT-wise, we're going to treat everybody like they're having a heart attack. You don't really say, oh, they're just having angina. Everybody's treated as they're having a heart attack. So you give them high concentration of oxygen, non-rebreather, right? Request medical control to help the patient with their prescribed medication. And also, while you're there, request that you can give the patient an aspirin if they're not on any other anticoagulants, any other blood thinners. And then transport the patient or call for ALS backup. If you believe that the patient's having a heart attack, you need to call for ALS backup. So in your testing scenarios, that's what you're going to see. You're going to see call for ALS backup, contact medical control to do this. Right? So it's going to be a series of things that you have to do. Some of the questions may not give you the opportunity to call for ALS backup. So you're going to have to go ahead and go through the treatment. Does that make sense? All right. So the treatment's all the same, so that's good. That's good news. And then the other one is just a good picture of the sort of ischemic heart. You get this, mine would be the homemade vanilla being built up in my arteries here, and it's just restricting that blood flow, which is going to cause some ischemia. So it's very important to keep your cholesterol down, your blood pressure down, your triglycerides down, okay? All to keep a healthy heart. It's designed to run for a long period of time. The heart is. It's just what we do to it that causes it not to function so well. And then again, the clot, this type of clot, whether it breaks off, like Con was talking about, that breaks off and forms a clot, or if it becomes that clot breaks off and travels in the bloodstream and forms an embolism. So those two are not necessarily important to know the difference between, because they're all going to end up as a clot. It just depends on where that embolism stops, on what type of condition it's going to cause. If it breaks off up here, the only place for it to go is downstream and end up further down into the coronary artery.
Can you have more than one clot at a time, like in different arteries?
Oh, yeah.
It's possible?
Yeah, you can have multiple blockages. You'll hear people go in and get 2 or 3 stents put in place, or you'll hear someone go in and get quadruple bypass. They're having open heart surgery and they're having to jump those arteries. They can't clean them out. So they're having to go in and do open heart surgery where they take a vein from your leg and they'll go in there and sew it around there so blood can get around that area.
How do you take a vein out without it dying? Like, do veins die if you take them out? Like, if you leave them out for too long?
Well, it's like a fish. I mean, if you throw it over there on the floor, it's going to die eventually. But
yeah, but fish take a while to die.
They take it out and put it back in.
So the part they took off, they take out the whole thing, or just like part of it?
Just part of it.
They like piece the vein together.
Yep, just like a tube. They cut it, pull it together, piece it together. So other signs, we look at this, the signs and symptoms are the same between angina or the MI. Palpitations. Remember what palpitations are? Yeah. Palpitations, huh? Yeah, fast and hard. If I drank an energy drink, I would get palpitations. My heart would go like that.
Like after you run?
Yeah, that's true. You could run. If you're out of shape, you could get palpitations. All right. Radiating down to both arms.
Oh my God, it's the worst.
Dyspnea, nausea.
The worst.
And this anxiety feeling here, last thing you ever want to hear a patient do is tell you, oh, I think I'm going to die. For some reason, they get that weird, yeah, I don't know what it is, but the majority of my patients, just as long as they're not over dramatic, but the majority of my patients who they're sitting there, they're having chest pain, oh, my chest is killing me, this pressure's too much, oh, I just think I'm going to die.
They die.
Don't say that.
They die, right?
They die. Most of them end up dying. Not in days, in minutes. Sometimes before we can just get them out to the truck, they go into cardiac arrest.
So if you have a patient and you're in the ambulance on the way to the hospital and they die, do you still take them to the hospital?
Yeah, they'll take them
Yeah.
Yeah. We never deliver anybody to the hospital without a pulse and not breathing. Is that a true statement?
Wait, what?
We never deliver anybody to the hospital without a pulse.
No, that's false.
Why is it true?
Because they forgot to make hospitals.
Huh? We make the pulse. We generate the pulse. We do CPR. So when we're going in the hospital, they have a pulse. I can feel it. Every time that I do this, they generate a pulse and bag them. They're breathing. So we never deliver anybody to the hospital without a pulse.
So you just continue CPR?
CPR. Yeah. All the time. It would be bad form to deliver them without a pulse.
Okay, what if they're dead on the scene? Do you still take them?
Don't take them.
What do you do with them?
Leave them there.
For real?
Yeah.
Are you lying to me? I think you're lying to me.
No, the birds come along.
Oh, you're such a liar.
Birds, they might have animals. They might have cat.
No, it's a serious question.
They won't have to get dog food for weeks.
This is a serious question.
No, because that thing, what are those things called? The coroner or something like that? They come.
Yeah, the coroner come pick them up.
Bro,
Unfortunately, I experienced that.
Yeah.
you wonder why I hate you.
No, I don't.
What? That's terrible.
That's why.
Okay, so we look at other vomiting. The abnormal heart rates. Not too often you're going to have a tachycardia, but you may have a bradycardia. The heart will start slowing down due to the hypoxia, the ischemia, and usually a bradycardia in a MI is a bad sign. Some of it is a normal sign. So don't get too freaky over the bradycardia unless it's just real low and it's causing a decrease in cardiac output, okay? Because an inferior wall, or if they're having a heart attack on the bottom side of the heart, they're supposed to be bradycardic. That's a normal presentation. A normal presentation of an inferior wall MI is hypotension and bradycardia. That's normal. You shouldn't try to change that or you're going to kill the patient. All right? So if the patient is tolerating it, then don't mess with the rate. You guys can't do anything for the rate anyway, but try not to get that rate up. Abnormal blood pressure, it usually takes place when the patient's in cardiogenic shock. We'll talk about shock over a whole lesson, but cardiogenic shock is usually fatal. It's the problem with it is the pump is just gone. The heart pump is gone. It's like a motor in a car that goes out. The only fix is to replace the motor. So we look at it. Anybody really with having cardiac-related chest pain needs to go to the hospital. They need to go to the hospital by ambulance because they need the oxygen. Oxygen's been proven to decrease the infarction size. They need the medication, and they also potentially need the AED that you might have. They could go into cardiac arrest en route to the hospital. I can't tell you how many stories I've seen some of it. Working in the ER, Grandma would pull up with Grandpa in the front seat, and they'd be in cardiac arrest. If they would have called an ambulance, then that person would have went in cardiac arrest in the back of an ambulance with a defibrillator, right? With drugs, CPR. There would a higher probability of a resuscitation. No probability of resuscitation in the front seat of the car, right? So, anyway, history, no nitroglycerin, that's a problem. Systolic blood pressure is low. But we're just focused on any type of cardiac problems. Now, the hospital that you want to go to, you want to make sure that if someone's having a heart attack, that you take them to a hospital that has a cath lab to it, or has a hospital that is able to give them thrombolytics. Typically now, they're looking at you take them to a hospital that has a cath lab. They have this whole new thing that you're going to look at. It's called a STEMI, and a STEMI stands for ST elevation MI. I think I have a picture. Yes, the STEMI. ST, that's the ST segment, elevation MI. So ST elevation myocardial infarction is what STEMI means. They've launched, some time ago, they've launched a program where if the ambulance gets on scene and they have an ECG, a 12-lead ECG that looks like this is ST elevation. We'd have to go back and review the ST segment, but y'all remember a little bit about that? Mm-hmm. QRS, ST. The ST segment is between the S wave and the T wave, or right here. Can y'all see where I'm pointing to? Mm-hmm. That's off the isoelectric line, and that's elevated. See how that ST segment goes straight up? Well, STEMI is someone that's having ST elevation, 1 millimeter or 2 millimeters more or more of ST elevation in consecutive leads. And this gives you a good picture of what consecutive leads are, because it's color-coded. These are consecutive leads. All right? So this person is having ST elevation in the inferior leads. That's what these leads are right here. 2, 3, and AVF are inferior leads. So this person's having an inferior wall MI. What they're also having is reciprocal changes. Reciprocal changes is over in the opposite leads. See these right here, V1 and V2? If you were to flip those over, it would look just like this. That's reciprocal, the other way. So reciprocal changes the other way. Now, you guys won't do these. EMTs don't do the 12 leads, okay? But you'll be around them. You'll be on the ambulance. You'll be in the ER. Some of you guys have already done 12 leads in the hospital, right? In the emergency room. So I bring this up just sort of to show you what they're looking for. All right. So if you hear the word STEMI, code STEMI, that means they're bringing in someone who's having a heart attack. And this is a picture. See the purple ones? These are all the same leads or the same views. 1, AVL, V5 and V6 is a lateral MI, meaning they're having a heart attack on the lateral side. The green would be anterior or the front. And then this blue is the septal wall. The wall in between. You can have a heart attack on any surface area of the heart. And what a 12 lead does, it gives you 12 different views. It gives you sort of a camera. It gives you these short views of the heart, electrical wise. Now they're only good about 30% of the time. You can have what's called a non-STEMI, All right, which means that the patient's still having a heart attack, they're just not having electrical changes with the heart attack. So even if I put the 12 lead on the patient and there is no ST elevation, but they're still having signs and symptoms of the heart attack, they're having a heart attack until proven otherwise. I can't prove that if they're not having a STEMI, I can't prove that pre-hospital. I have to take them to the hospital and draw lab work. Anybody remember what lab they look for? Starts with a T. Sounds like trampoline. You're right. Troponin. Well, your dad's a cardiologist. You'd know anyway. Troponin. That's right.
That does not sound like trampoline at all.
Yeah.
That does.
It's already fun shooking up.
Troponin. So non-STEMI MI, they take them, they're drawn lab. If they have an elevated troponin, then they're having a heart attack. They're treating them as they're having a heart attack. All right? So here's sort of your algorithm. They're having chest pain. You provide them oxygen, reassure them. The nitroglycerin, the aspirin, system with the medication, reassess, monitor vital signs. All right? So the treatment for angina or if you really highly suspect they're having a heart attack, it's the same. It's no problem. Get a good sample history. Rest. Don't overexert the patient. Don't exert the patient at all. Give them oxygen. Request the orders for the patient's nitro and potentially some aspirin. Everybody good on cardiac chest pain related?